Well, good afternoon and welcome to back to the 2024 NECOM and MARCOEM joint seminar series. Um, Doing this in collaboration with the Johns Hopkins Education and Research Center. I'm Chris Spicer. I'm the Director of Continued Education here at Johns Hopkins. Today we've got a great seminar from Dr. Warner Hudson on immunizations and occupational medicine. Following Dr. Hudson's presentation, I will be facilitating questions. Just put your hand up or put a message in the chat. I'll try to keep track chronologically as best I can. And just call your name out. With that, let me introduce Dr. Hudson here. Warner Hudson's Associate Clinical Professor of Occupational and Environmental Health at UC Irvine. Prior to this, he was Medical Director of Occupational and Employee Health at UCLA for the health system and campus there. He has years of experience designing, leading, and implementing occupational health strategies and programs for research and animal workers, healthcare personnel, travel, and fieldwork medicine. He was a voting member of the UCLA IBC for 7 years and has published and presented numerous articles and sessions related on biosafety issues. He has been clinically active in this area as well for over 40 years, and he's a past ACOM and WOMA president. And I'm very much looking forward to hearing what you have to say here, Dr. Hudson. And that I'll turn it over to you.
Thanks, Chris, and welcome everyone. It's an honor to be here. There's a lot of stuff to cover, so I'm going to go kind of fast. And let's see, slides are not advancing, even though we practiced this. There we go. I have nothing to disclose. There are really two ways to go about this. One is to go through the different groups of employer types and which vaccines they need, and the other is to go through the individual vaccines. And I've chosen to pick going through the vaccines themselves. So apologies to those folks if you've got a specific employee group you're interested in. So we'll start out with apologies. I had a little bit of a URI a couple of weeks ago, and with a person with asthma all my life, I am a little bit hoarse still. So as you all know, COVID is upticking this summer, and all the indices are up. And I've thrown a few travel photos from recent trips. That's a tiger and Bandafkar from earlier this year. So this is the CDC multicolor chart where you can see what is trending in terms of subvariants. And you see the KP.3.1.1 and the KP.3 kind of leading the hit parade. No surprise to most of the people on this call. And the good news is the vaccines that are about to come out, which are queued up, most of them are made and ready to ship, are just awaiting FDA approval, and then they'll be shipping out, and we'll be able to get the monovalent vaccine shortly. And in communication with at least one of the manufacturers, they will cover the ones that are trending up right now. So the current monovalent vaccines are for the XB.1.5, and the ones that come up, the CDC recommends every 6 months. If you're, hang on a second, got to move this thing out of the way. In order to get updated vaccine, whether or not you're previously vaccinated. Unfortunately, only about 22% of adults got the vaccine last year. Moderna, Novavax, and Pfizer will have the new vaccines as soon as they're available. And what FDA says they prefer the recipe based on the JN1 and KP.2, which includes the ones I mentioned, which are descendants of those. So get it once, or if you're over 65, you can get a second one 60 months after that. And if you're immune compromised, it's flexible to getting it up to every 2 months. But if you're severely immunocompromised, probably the vaccine is not enough. You ought to get Paxlovid if you're getting symptoms. That's a little puppy wild African dog from Africa last year. So COVID vaccine does reduce long COVID, and the people who have COVID, long COVID that goes into remission is twice in the vaccinated group what it is in the unvaccinated group. There are a bunch of side effects I'm not going to go through. One that was notable to me is the COVID arm, which Pam actually got, which is that red itchy arm that appears a day or more than a week after vaccine. Antihistamines help. You can still get vaccinated. And American Academy of Dermatology has advice on this. And so we keep seeing interesting side effects. More of those wild African dogs in front of the Jeep, baobab trees. So the new flu vaccine should be out soon. It's a trivalent only this year. The B Yamagata, one of the B's was removed. The egg-based one has H1N1 Victoria and H3N2 Thailand and B Austria. The recombinant and the cell-based, no egg, have H1N1 Wisconsin, H3N2 Massachusetts, and the same B Austria. So slightly different, but should cover just as well. So this year we'll have the standard dose egg-based and cell-based flu cell vax, and then for the plus 65 group, we'll have the recombinant flu block, the egg-based high-dose flu zone, and the egg-based adjuvanted flu ad. So those are the ones that people in my age bracket look at, those last bolded three. And we did a WOMA webinar about a month ago with an ID person and a poultry vet on the H5N1. And so it keeps causing mild illness in workers. Everyone is gearing up for the potential that it could change and become more transmissible or more serious in humans. The U.S. is paying Moderna to make mRNA H5N1 vaccine, and Finland has started vaccinating some of its animal workers against the H5N1 bird flu. We have some of the older vaccines that were licensed against H5N1 in the national stockpile. So we think we're in okay shape, but I know it's always a scramble when these things happen, as if people don't remember that these things can happen. You might know there's new RSV vaccines out. FDA has now approved 3 of them. Apologies on the pronunciation. There's Arexvy, Abrysvo, and Resvia. The Arexvy is an adjuvanted recombinant subunit glycoprotein antigen for adults 50 to 59 and for those above 60. It's the only one at the younger age group. The other 2 are for 60 plus. One's non-adjuvanted, and then there's an MRA one. ACIP now says everybody over 75 should get one of these vaccines, and the adults over 60 with risk factors should get a single dose. And the risk factors are those listed: heart, lung, nursing home, long-term care, musculoskeletal, chronic kidney disease, liver, blood. So if you've already received one RSV, another dose is not recommended. It's one injection. There's some mild side effects locally, and it does reduce RSV by a lot, 82+%. A lot of hospitalizations and deaths. So again, you see the groups that it's recommended for. The pneumococcal vaccines, yes, there's yet another pneumococcal conjugate vaccine, the PCV21 Capvaxive, which was approved in June of this year. It has 11 strains that were not in the PCV20. The PCV20 covered 58% of the invasive strains in adults, while the PCV21 covers up to 84%. So it's a substantial improvement. However, it doesn't cover one type, type 4, in the older PC20, which affects homeless people that are at quite high risk, and Alaska and American natives that are also at very high risk. And it's recommended for people 18 years and over. And it's so complicated to remember the Pneumovax schedule that CDC now has a Pneumorex app you can download. I have a picture of it there. And when you click on it, you then start typing in the information, and it will tell you what the people need. And I would suggest you use that, because I can't remember all the pneumonia vaccine stuff. This is a moonbow at Victoria Falls at a full moon at night. See the star lighting up that the mist from Victoria Falls. So there is one approved Ebola Zaire vaccine. Some of the special lab workers may get this if we are receiving Ebola specimens. It was approved in 2019. It's a live attenuated vaccine based on recombinant vesicular stomatitis vaccine. Single dose is very effective. There are a couple investigational ones, which are not yet FDA approved. Only has the gene for the glycoprotein in Zaire. You can't get Ebola from the vaccine. It's not effective against the other strains like Sudan, which occurred in the outbreak in Uganda that ended last year, or Marburg. So it's usable in outbreak responders, lab scientists, staff working at BSL-3, and healthcare personnel caring for transporting suspected patients. It is in the national stockpile. It's not strategically commercially available yet. It is available through the CDC if you need it. And there's an IND for a booster if you need that. There was a Marburg outbreak last year, if you remember. There were a couple of them, one in Equatorial Guinea and one in Tanzania. And it's over. Those little outbreaks are over. There's no vaccine or treatment for this strain yet. This Marburg, remdesivir has been tried, does a little bit of good. Some vaccines are in promising trials, also VSV based, and these have been effective in macaques. So I'd stay tuned for what we see on Marburg. That's the same falls at daytime sunlit double rainbow. So Hep B vaccine, you might realize there's been an increase in certain age groups, in middle ages. 80% of the people that have Hep B are unaware. About a third of adults are not vaccinated. Back in 2022, CDC recommended universal Hep B vaccination for 19 to 59, said everybody should be vaccinated, and over 60 with risk factors. Over 60 without risk factors may be vaccinated. And then in May of last year, they said universal screening recommended once in each person's life at age 18 plus with a triple panel, surface antigen, anti-HBs, and anti-HBC. So there's a new HEPLISAV vaccine that came out, what is this now, 4 years ago? That's 2 doses. The others are 3 doses, 0, 1, and 6 months. It has, there's about half the completion rate for the 3-dose varieties compared with HEPLISAV 2-dose. It's not for pregnancy, not enough data. It has an adjuvant, CpG 1018, and Jerix has an alum adjuvant. The HEPLISAV is faster to protective antibody levels, especially important for older and diabetic patients who don't mount an immune response quite as well as other groups. It's more expensive for some groups like incoming med students, but for other people, maybe time to move to this quicker to get protected vaccine. Prehevbrio was approved in November of 21. It's another 3-dose like Engerix and Recombivax. It's 3 antigens, recombinant from Chinese hamster ovaries. The others are recombinant Hep B surface antigen from yeast cells. It's, again, not recommended for pregnancy. Higher levels of protection, faster than the other 3-dose vaccines, but again, it's 3-dose. Its per dose price is somewhere between Engerix and HEPLISAV. So some considerations: a 3-dose vaccine in childhood, like incoming med students, it might be cheaper to go with 1 dose of Engerix B booster and then a titer. CDC prefers you stick with one manufacturer for a series. So when feasible, use the same manufacturer's vaccine. But if the vaccine had to be preferred because the vaccine of that manufacturer is not available, go with a different manufacturer. The 2-dose vaccine, at least 4 weeks apart, is only for HEPLISAV, not for any of the others. You can't mix the others in. So a series consisting like of 1 dose of HEPLISAV and a vaccine from a different manufacturer, you'd stick with a 3-dose schedule. So for a short timeline, HEPLISAV is a better choice like travel. Hep A, so we've got Havrix and Vacta, single antigen inactivated. It's 2 doses, 6 months apart, at least 6 months apart. You want to get at least 1 dose in before you travel, 2 to 4 weeks before you travel. Twinrix, remember, is the 3-dose series at 0, 1, 6 to 12, or 18 months of Vacta. And there's the accelerated 4-dose schedule at 0, 7, 21 to, should say, 30 days, and then 12 months. And adult B dose has adult B dose, but a PEDS A dose in it. So it's not recommended, therefore, for post-exposure Hep A prophylaxis. The live attenuated vaccines, which are available elsewhere, are not available in the US of A. So for pre-exposure travelers or working countries high risk, it's a good choice. Occupational exposure, if you work with HAV-infected animals, primates, or you work with HAV virus in a research lab. It's not routinely recommended for healthcare personnel. Post-exposure, it is in an outbreak, and sewer workers, childcare workers, and food service workers, it's not currently recommended for those groups by CDC. So from up to date, this is the schedule that has the doses. You can see the amount of antigen of B and A in this from their table in the up-to-date article currently, as well as the schedules that I mentioned. Switching to TB, there are a whole bunch of new TB vaccines in the pipeline. The phase 3 thing on the right-hand side of this slide, the numbers of things in phase 3 trial has grown each time I look at this. So I would expect we see some TB vaccines become more widely available in the future, other than the old BCG. So there are increasingly new vaccines available. There's a couple of them that are being used now that are being tried in Africa. So keep your eye on those. Switching to polio now. So for polio, the CDC has a map of which countries have wild and which have vaccine-related polio. That's Valley High in the background in Tahiti. So this is a WHO map, which is a little clearer to see which are wild type and which are vaccine-related polio. So there's ongoing transmission in Pakistan and Afghanistan, and vaccine-related in about 22 countries. So there's a lot going on. If you remember, a couple of years ago, there were some cases of Sabin vaccine-related in New York, Israel, and the UK. It is recommended, as I think most of you know, that all travelers should get an inactivated polio booster. If they're going to a destination that has circulating polio, I think it's good just for anybody traveling to have one booster in their life. If you've completed your routine polio boosters, your routine series, and you haven't received one adult booster dose. There are some countries that want you to be vaccinated between 4 weeks and 12 months before you leave polio-infected countries. So you may want to get it before you go to those places. Saudi Arabia and India, or a couple of those, having been in India earlier this year, they didn't seem to check. I think Saudi Arabia is more vigilant about this. So it's probably good to err on the side of caution with the polio vaccine going to those countries. And the documentation is like you would do for the yellow fever vaccine if you're traveling internationally to those countries. It's also for certain lab workers and healthcare personnel, of course. So diphtheria toxin research, as you might remember, it has a very low LD50, 100 nanograms per kilogram. So it's important to stay up to date with Tdap or TD vaccine if you're going to work with diphtheria toxin research. The toxoid, the vaccine, is inactivated toxin. It's made against the B subunit, which has to do with attachment. The A subunit has to do with what goes on inside the cell. You can't assume that the vaccine will protect against all lab toxin exposures. Some exposures may exceed the antibody level, the protection provided by the vaccine. So you should stay vaccinated within 10 years. Berkeley uses 2 years, or get a whole 3-dose series. Some require baseline IgG levels above 0.1 international units per mil prior to beginning high-risk research. Duke does that. So if it's below that level, you need a booster and a retiter a month later. The diphtheria antitoxin is made against the B subunit in horses. Of course, passive antibodies only neutralize the toxin before cell entry. So you got to administer it quickly as the toxin attaches to the tissue receptors by 3 days. If you need DAT, you got to contact the health department. They'll get it from CDC. It has anaphylaxis risk, serum sickness risk, but it does reduce mortality. So switching to typhoid, there's currently XDR typhoid in Pakistan. It's been identified in Southeast Asia, South Africa countries, and it's been introduced by travelers in Canada, the US, and UK recently. There are the 2 vaccines that you remember, the polysaccharide, 1 IM injection at least 2 weeks before departure, it lasts 2 years. And the attenuated live bacteria, which is the 4 little teeny tiny capsules in blister packs. Easy for them to bounce out and go down the drain. I've had that happen with a number of travelers. They're surprised when they push it and the thing shoots out and is gone. You got to maintain the cold chain from the pharmacy, bring it to the home fridge as 1 capsule every other day on days 1, 3, 5, and 7. You take it an hour before a meal with cool water, and you want to complete it a week before you travel. Remember, you can't be taking antibiotics while you're taking this live bacteria attenuated vaccine. Some of the anti-malarial prophylaxis drugs are okay. It's not for the immune compromised. This one lasts 5 years. We used to think the oral was more effective. More recent studies say they're equally effective. Also, for clinical lab workers who are getting specimens of typhoid, it's recommended. There is a cheap, inexpensive typhoid vaccine available from a manufacturer in India. And for people 6 months and older, appears to be fairly effective. It's cheap, so not available for Americans, but if you're working internationally, maybe something to look at. Switching to meningococcal vaccine, the quadrivalent vaccine is recommended for travelers who are going to spend a lot of time like living or working with the local population in the meningitis belt, which is on that screen, December through June. Adults who are previously vaccinated with quadrivalent and at risk should get a booster 5 years after the primary, and then every 5 years if you live in or travel to those hyperendemic areas. There's some age limits apply, like Menveo is only up to 55, unlike the other one. The B vaccine is not indicated for travelers, like to Hajj also. Hajj or the Umrah pilgrimages required for Saudi Arabia got to be within 5 years prior to arrival. Microbiologists with routine exposure to meningococcal ought to get the quadrivalent plus the B. If you're in that very young age group, you could, I suppose, get the pentavalent vaccine that's available now recently. But I don't know how many of those lab workers are in that age group. But we used to have a lot of the clinical microbiologists and the PEDS ID folks and fellows come to us for meningococcal vaccine at UCLA. So they fear those diseases as they should and want those vaccines. This is just a sheet from the MMWR in 2020 on the lab groups that get the meningococcal vaccines. And I won't go through it in detail, but it's in the MMWR in September of 2020. So for travel, Menactra was discontinued in 2020 by Pfizer, but it was replaced by Menquadfi. So we now have Menveo, 2 months to 55 years, and Medquadfi, 2 years and older for adults who are traveling. They're both conjugate vaccines. Menveo uses a diphtheria conjugate and Menquadfi a tetanus toxoid conjugate. It's one IM dose, 7 to 10 days before travel. And like I said before, if you received a primary dose, you get a booster after 5 years and every 5 years thereafter if you live in or travel to these hyperendemic areas. Again, meningococcal B vaccines are not recommended for travel to the meningococcal belt areas. Rabies vaccine, pre-exposure prophylaxis was updated. Amy Berman did a super job going over rabies stuff. Was it last year, Amy, or the year before? I had a rabies case. And,
not this year. I think the year before.
And Marcia Isakari from UC San Diego has done a lot of work and presenting on these. But basically, pre-exposures for travelers, lab personnel, and certain animal workers and researchers. It's 2 IM doses a week apart, and it protects up to 3 years. There's a table I'll go over. Boosters with titers need to be at least 0.5 international units per the table, and there's 5 different risk groups now. If you're vaccinated, the post-exposure are a lot simpler. It's only wound cleansing with soap and water, TD or Tdap, and 2 post-exposure vaccines, dose 0 and 3, not 4 like for the unvaccinated, and you don't need HBIG. So for people at risk, the pre-exposure rabies vaccine is really a good idea, and there's plenty of it out there in countries like India. If I have time, I'll talk about the problem with the vultures and the diflucan there. So this is too hard to read, but basically it's the 5 rabies groups, who that usually consists of, and what the recommendations are in terms of dosing and titering. And the titering is the things that change the most. So really look at that. It's hard to remember this stuff. So if you need people for pre-exposure prophylaxis, this is the go-to table from the CDC. Now, malaria vaccines are coming along too, like the TB vaccines. There are a couple of vaccines out. there's an RSS and an R21. The RSS is called Mosquirix, and there are pilot programs going on in various parts of Africa. These two vaccines and the new one that was announced yesterday at NIH are against sporozoites, that little phase of the parasite. These all require a booster. The new one that NIH is working on, announced yesterday, won't require a booster. I don't have a slide on that one yet, but these malaria vaccines will have a big impact, especially on the very young and the pregnant people that are severely impacted by malaria. So keep your eye on those. Dengue. So again, dengue is a flavivirus like Zika, West Nile, Japanese encephalitis, yellow fever, tick-borne encephalitis, and some others. It's the second infection that causes the vascular leak syndrome with a high fatality rate, decreased platelets, DIC, fatal organ hemorrhage. You diagnose it with a positive PCR and IgM early and IgG late. There's a vaccine, Denvaxia, a 3-dose live attenuated tetravalent vaccine, was approved in 2021. And Sanofi plans to discontinue it September of next year. I think there's lack of interest in it. It's currently available, but these doses will expire in 6 of 26. And really, it's not so much an occupational medicine vaccine. It's only for kids with prior infection, aged 9 to 16, who are living in areas where dengue is common, which are listed there: American Samoa, Puerto Rico, U.S. Virgin Islands, Micronesia, Marshall Islands, and Palau. But you have to have a lab diagnosis of prior infection to get the vaccine. That's a requirement. It's not recommended for U.S. Travelers. However, as the first 6 months of 24, there are a lot of dengue cases going on. 10 million cases so far in North, Central, and South America and the Caribbean, which is twice the whole year of 2023. So I suspect increase in dengue vaccine will keep growing. I mean, there have been small outbreaks in the U.S., local transmission in Florida, Texas, Hawaii, occasional cases in California, Arizona. And I noticed in the part of Italy where Rome is located, there's some dengue going on. So it's growing as the climate keeps getting warmer. So keep your eyes out for dengue vaccines. Switching to yellow fever. Excuse me while I get a sip of water. So the CDC keeps updating its yellow fever vaccines for South America and for Africa. This one looks a little different in colors than the previous one, and there's subtle changes. So always look at these maps when you have travelers. For those of you who do travel medicine, for all the researchers and clinicians and others, speakers that go to countries. This is the Africa map. Brazil had a bunch of deaths and travelers who were unvaccinated with a high case fatality rate back a few years ago. It's not required, it's only recommended. There's some countries that recommend you have gotten vaccine if you've been to a yellow fever area like Brazil. So pay attention to these requirements. It is recommended by Brazil, even for travelers to go to Iguazu Falls, where you might not think you need the vaccine. But there are a lot of parts of Brazil now that have yellow fever going on, along with dengue and other things that are happening in Brazil. Remember, it's translated by Aedes aegypti in jungles and urban areas. You need that certificate of vaccination. The vaccine came back in stock. There was a spell where it was kind of hard to get. There's a link on the CDC yellow fever site in the Yellow Book where you can find the vaccine centers where you can send people if you don't do it at your clinic. The certificate is good for 10 days after you vaccinate, and then it's good for life. If somebody has a waiver, you can get that and write the letter before departure on letterhead and so forth. It's no longer recommended over age 60. And the SAGE group from WHO ended booster recommendation in 2013. And WHO said a booster is not needed since 2016. So it's mostly just a one dose. There's in the fine print, if you dig deep into these articles, it says, well, there's some people that are, not getting enough mosquito coverage in high areas where they might consider a booster. So, but for most everybody, it's one dose. This is a leading UK specialist that died at age 67 a week after he got a yellow fever vaccine. Now, I understand he may have had viral hepatitis as an underlying personal health condition, but here's a guy that was a very smart MD specialist who died after getting his vaccine. So it is something to be concerned about. Live attenuated sub-Q vaccine. Generally few side effects. I didn't have any side effects when I got mine or my booster. And again, on the vaccine, a lot of people sort of hit those years where they can go traveling, and then they discover they're in that age group where they can no longer get yellow fever vaccine. So it's a conversation to have with your folks before they travel to get it well ahead of time. In some situations, the risk of yellow fever outweighs the risk of vaccine in pregnancy. Corticosteroid treatment, if your dose is 20 milligrams or less, it's okay. There are a lot of people where you have to take them off of their immune suppressant drugs, like if they have various rheumatologic conditions, then give the vaccine, and then hopefully they don't get too much worse with their psoriasis or rheumatoid arthritis or whatever, and they go back on them after they've gotten the vaccine and gotten through that. So if you're going to give it over 60, which some people may be brave and do up to 65, I'd probably think twice about that. You definitely have to have a conversation with them. I was in the room in Zambia last year, Little Frogs. Again, it's an attenuated strain. The immediate hypersensitivity reactions are rare due to egg allergy. There's neurotropic disease that's even rarer, which is bad. And there's the viscerotropic disease. And all these bad things have occurred in people getting their first dose. But age is a risk factor. You can see down at the bottom, those last few bullets, the risk of these things goes up as age advances. That was Bora Bora for those who haven't been there. Beautiful. So live cholera vaccine. There's only one cholera vaccine approved in the US. The manufacturing distribution was temporarily halted back in 2020, but it's resumed. In clinical trials, it does work pretty well after a vaccine for a few months. It's a single dose oral vaccine. And the duration beyond 3 to 6 months is not known at this time. So it's a short-term thing. You need to get at least 10 days before cholera exposure. I have not given it, and I spoke to the ID people at UCLA a couple of years ago. They haven't given it out either. Most people aren't going to areas where it's the middle of an outbreak where they really aren't going to be taking precautions. So it's got limited use. WHO has pre-qualified 3 other vaccines that are not available in the US. Hand hygiene, food and water safety, and just basic good nutrition is important. But cholera is making a comeback, as the little white box up top reflects. So I think everybody heard this in the last 24 hours. Yesterday, WHO declared a global health emergency of significance because of rapid spread of Mpox to neighboring countries from the DRC and a dozen other countries. This spread is clade 1B. We've had no cases of that in the US so far. This one, the one they declared an emergency about, is more transmissible, even among children with just household contact. And it's more serious, more deaths per population than clade 2, which is the one that's just cooking along in the US since a few years ago. Jynneos, to recall, is a replication deficient attenuated vaccinia ankara, smallpox monkey virus vaccine. There's no take, there's no risk of inadvertent or auto transmission like there was from the older one that we used to use. FDA licensed this in 2021 for 18 and older. There was a pre-exposure MMWR in 2022. There's not enough data on pregnancy and lactation. There are a lot fewer side effects than the old ACAM 2000. It's only contraindication severe allergy to a vaccine component. It's estimated about 85% effective against monkeypox. That's possibly an overestimate. There were some monkeypox cases in Chicago a year ago in people that had had 2 doses. It seems like these breakthrough doses are rare, and when people get them, they're much milder. So there's less concern about it today than there was a couple of years ago when we first started seeing these. It's 2 doses sub-Q or 0.1 intradermal when there weren't enough to go around. There's emergency use authorization for the intradermal. I think most people would rather give or get the sub-Q if they need it. It's considered effective 2 weeks after you get the second dose. Right now, there's an adequate supply for the sub-Q as routine. People who got the ACAM 2000 still ought to receive 2 doses of the Jynneos. It's been commercially available since April of this year. I don't know how many of you have tried to get it, but it's now available not through the state health department and the CDC. You can use it for pre-exposure prophylaxis as well as post-exposure in the specific risk groups and situations that it's recommended for. For post-exposure, you can give it first dose within 4 days of the date of exposure to prevent onset, and then between 4 and 14 days, it'll reduce the symptoms, but it may not prevent disease, so that's good. Let's see. So the interim considerations from this year for use of vaccine. For those at occupational risk, a booster is recommended 2 to 10 years, depending upon the type of work involved. There's a slide, the next slide upcoming on that. This includes research lab personnel who work directly with cultures or handle animals contaminated or infected with monkeypox virus. It's not recommended for clinical lab personnel doing routine chemistry, hematology, UE testing, including patients or those suspected or confirmed monkeypox, healthcare personnel who take care of monkeypox or administer ACAM 2000, which we aren't doing too much of anymore. So it's got a narrow bandwidth for people who should get it in the health field. It's felt that the recommended infection control practices are effective in minimizing transmission. So the vaccine is offered based on the site and activity-specific biosafety risk assessment. So that would include lab procedures with high likelihood of generating aerosols or inadequate PPE availability. So the Jynneos booster, those who receive 2 doses and are ongoing risk should receive a booster every 2 years. Those who receive 2 doses and are at ongoing risk with a less virulent strain get a booster every 10 years. They also recommend that people that got ACOM and ongoing risk receive a booster of Jynneos as an alternate. They switched that to 2 boosters. If you switch to Jynneos boosters, stick with that frequency instead of the ACOM. Antibody testing is not recommended if you're immune competent. And again, the breakthrough rate, if you're vaccinated, is rare. So boosters are not recommended in the current outbreak for everybody. And interestingly, this is the standard CDC adult immunization schedule by risk group published earlier this year. And you see monkeypox next to that red bar down in the lower left. Monkeypox is on it. And the details are in the footnote. So that's a change as to how common that's becoming. So the new tick-borne encephalitis vaccine, Ticavac, was licensed in August of 21. It's been used for over 20 years in Europe. ACIP recommended back in 2022. Now CDC recommends. It's an inactivated whole virus vaccine. It's 0.5 ml IM, then a repeat 1 to 3 months, and then 5 to 12 months after the second dose, a booster. And then a 4th dose 3 years after completing the series if there's ongoing exposure. Only contraindication is severe allergy. There's not enough data for pregnancy and lactation. This is the map of where tick-borne encephalitis is across Europe and Asia. A lot of the people in these countries where it's common are giving their population tick-borne encephalitis vaccine. And there was one school, a prep school, that sent a young person over to China for a broad program, and she got tick-borne encephalitis, wound up with a severe CNS disability, and sued, I think it was Hotchkiss School for, I think, 42 or 37 million, and won. Said the school didn't really warn them enough and give them an opportunity to decline the vaccine. So it is something worth mentioning to people that are going to these areas, even though the risk is low. This was a tiger cub chasing a red-wattled lapwing down there in Africa earlier this year. So the FDA did approve this vaccine in 21. The risk is very low for most travelers who are visiting countries where it's found. However, you might be at increased risk if you're going to visit areas where ticks are most active April through November, and you're involved in a lot of outdoor activities in or near forested areas, hiking, camping, hunting, fishing, bird watching. So there is a schedule that they publish of the 3 vaccines for adults there, and the decision-making matrix that you see below. Most people are asymptomatic, but a certain percent have long-term sequelae, and 1 or 2% are fatal, as I mentioned in that case that resulted in the lawsuit. You may have seen, or perhaps you didn't notice, that ACIP does have a recommendation for a new chikungunya vaccine. I'm not sure how to pronounce it. Ixchiq, looks like, for 18-year-olds plus travelers, lab workers, potential exposure to virus at BSL-3 and those handling, but it's not for those just handling clinical samples. It's a live attenuated vaccine. It's a single IM dose, no booster. It's very effective. It's contraindicated in immune compromised, and pregnancy and breastfeeding precautions exist. The chikungunya map is, much of the middle part of the world where it's warm, and I'm sure we'll see or have already had some in the U.S. That's a 5-year map up there. Down below is where there's currently an outbreak reported. In May of this year, it's in the Maldives. And there's a graphic of who is really at strong consideration for vaccine. Tends to be the older and the very young and the type of travel. So look at these things on the CDC sites. Anthrax vaccine, I'll touch on briefly. There are now 2 anthrax vaccines. There's the older Biothrax and Cyfendus. For pre-exposure, just the Biothrax vaccine for 3 groups of adults who might be at risk. Some lab workers who work with anthrax, some people who handle animals or animal products, such as vets who handle infected animals, and certain U.S. military personnel. It's a 5-dose series at 0, 1, 6, 12, and 18 months, and they're yearly boosters, and then I think it's every 5 years. The other part is, whoops, let me go back. Oh, every 3 years if not high risk. Post-exposure, if unvaccinated, is either vaccine. It vaccinated with either vaccine. Post-exposure, you can use either vaccine. Pre-exposure, you can only use Biothrax. Post-exposure, remember, it's 60 days of antibiotics, 42 days if the vaccine was initiated. There's a schedule, and you get the vaccine times 3. You give the vaccine sub-Q, IM if it's an emergency. If the sub-Q is too hard, it doses 0, 2, and 4 weeks plus the antibiotics. The advantage of Cyfendus is it's only 2 doses, 20 days apart. So that's why Cyfendus is an improvement in the anthrax vaccine if we ever have a problem with anthrax locally or nationally. Just a reminder, there's a CDC vaccine schedule app. If you click on that app on the left of the screen, you'll get this next box on the right, and you can burrow into the vaccine details. And just a shout out to Mark Rusi and others who worked hard to update this infection control document in healthcare personnel that was last released in 1998. So it's been a very long time since this has been updated. Very good document for infection control and healthcare personnel. I think it's 77 pages, so it's well worth downloading and keeping and using. And it may not have some of the things that I went over that have just occurred in the last year since March, but it's a good document. And with that, I thank you, and we've got about 15 minutes for Q&A. Apologies if that was kind of a busy run through, but I'll stop and we'll open the panel for questions.
Well, Warner, I really appreciate that. You were correct. We were going over it yesterday. He says it's a dense presentation. He was also gracious enough to create a PDF of his presentation for us to share if anybody would like for us to send that to them. Amy.
Hi. So three things. First of all, thank you so much. That was just a phenomenal update summary. I feel like I have a lot of background reading to go do now. I would love to get a copy, Chris, of the PDF. I bet I speak for everybody. But I also have a question and might not have an answer. Early in your talk, you were describing the formulation of this season's flu vaccines. And I had not realized that it was different for the influenza A components between the cell-based and the non-cell-based vaccines. Do you know if there's implications or a reason for that?
Yeah, the implications are that they're expected to cover equally well the vaccine that's circulating. And I think it has to do with nomenclature of the strains that they used and not to be clinically significant. I dug into that and that's what I came up with.
Thank you.
Good question, though. I wondered the same thing when I saw it. Other questions?
I think Keith has agreed to go ahead and forward out the copy of the presentation along with the CME info. Did you include the photographs of your travels in the PDF, by the way?
I did.
Those were phenomenal, by the way.
Those are all pictures I took from trips in the last couple of years. It keeps forces me to stay up to date on travel medicine and infectious disease in all these parts of the world.
I certainly appreciate it.
Well, feel free to email me if you have specific questions. I know I did a fair amount of emailing before this webinar with, and I apologize if I'm not saying your name right, Les Wale, who's from one of the CDC network labs that handles esoteric specimens that are potentially bad bugs in bad outbreak settings and how to vaccinate their personnel. And Les was kind enough to send some of the documents to me that have been worked on, and they look quite good.
Thanks.
You could have a whole separate talk and I thought about a talk that includes the lab workers, one for people that work with different kinds of animals. You know, the pig workers need flu vaccine, so do the bird workers, and then the bat workers, and then the non-human primate workers, et cetera, et cetera. So there's a whole other talk where you sort of go at this based on which occupational group, childcare workers, and so forth. And unfortunately, if you do it that way, you don't get into as much detail about the specifics of the vaccines because you feel the whole time going through all the different groups. And my experience at UCLA and other places, a lot of the categories of workers overlap. Like you have clinicians that are doing research and that are traveling to esoteric places. So they fall into three different groups. And that happens so much that it's less valuable to do that. So I know there's a suggestion, and I saw when I looked at the article that Mark Rusi and others updated on infection control for healthcare personnel, that healthcare personnel currently excludes lab personnel and dental offices, among others. And there was a request, could somebody please write an article on what lab workers should get for vaccines? Because there's really no gold standard out there. In the article that Rusi et al. Published, it says, we didn't cover this because it's covered well elsewhere. It's outside of the scope of this article. So yeah, it's outside of the scope of the article, but it's really not well covered by other articles if you go to the references in that article. So it is correct. There's a need for that for the in-service worker. And yes, for people with goats, rabbits, and sheep, it would be great to have all those details. And that's true for so many hundreds of different categories of workers that almost becomes impossible to think of what they all might be And I'm always amazed at who pops out of the woodwork. I was part of a group that's written 2 articles in 2 parts. I think, Amy, you've been part of this, on bat workers in the field and in the lab, with rabies and 1,000 other things to think about when you work with bats. That's in Applied Biosafety in 2 parts. I know the first one was published. I've lost track of whether the second part of that has been published yet in Applied Biosafety, which unfortunately you need a subscription to get a hold of the article. Anyway, I could continue jabbering on, but are there more questions? If not, Amy's not sure either if that second part of the article is published. We've both been so busy we've lost track, and so many articles we've been on. Anyway, let me thank Chris and Choi from Johns Hopkins for hosting this, and for NECOEM and MARCOEM for inviting me to do this. A pleasure and honor. And again, if anybody wants to email me, I'm happy to try and keep up, although I am traveling next week, and then I'm back, and then I'm traveling again to walk, and then I'm out, and then I'm traveling again to Italy and Croatia. So it may be hard to reach for the next couple months, but I'll do my best.
Well, thank you for such a comprehensive presentation. I agree. That was great. Appreciate it,
pleasure.
Dr. Hudson.
Thank you. Take care.
And
Bye all.
everyone else.